I was invited to talk about how we work with chronic diseases in Sweden. I have not done a project or research or anything about this. I'm just trying to tell you how we work in Sweden on this. First, I will mention a little bit about healthcare in Sweden, so you have the context of the rest. And then something about management in general, and then two examples from two healthcare centers. And then I will end with a few reflections on this. First, primary care in Sweden. All primary care, almost, well, all healthcare is tax financed, and we have low patient fees. And most of the healthcare centers are public and some are private, but they're paid in the same way. They are reimbursed in the same way. According to the law, private and public care are the same. So it's general the same rules for all type of healthcare, all primary care. And the patients are free to choose a health center, and the health center get paid according to how many patients who choose to belong to that health center in general. It's a little bit different in different regions in Sweden, but that's the most common way. Sweden has quite a few doctors compared to Europe. I think it's 3.2 average in EU, and we have only 16% GPs. That's about half of the average in Europe. For all disciplines in Sweden, it's 5 years of specialization, and that is for GPs too. So everybody is a specialist. The way of working is patients book their appointments in advance. They call the healthcare center, and a nurse, it has to be a nurse, not a secretary, answers and talk to the patient, and often they get just advice on telephone and don't get an appointment. But maybe they get an appointment, and that could be with a nurse or with a doctor or with somebody else. We send out invitations for checkups, especially for diabetes patients, but for other patients too. And drop-in is kind of rare. It happens, but it's not so common. We have a gatekeeping role. It's not formal, but it works like that. And we have very few consultations if you compare to the rest of Europe. 1.5 per person visit a GP, but on the other hand, they stay longer. I read studies that GPs in Sweden and England spend about the same time with their patients, only it's divided into several locations, or they can see the same patient for many different problems at one consultation. About 70% of the patients who belong to that healthcare center come and visit the healthcare center or the GP in a year. At typical healthcare centers, there are several professions working together. Nurses, I wrote them first because in many special public healthcare, but also generally, there are usually more nurses than GPs in a healthcare center. And then there are physiotherapists and other professional groups too. And it can be a little bit different. They can employ what people they need for the population they have. Usually it's well equipped. We have a lot of air microscope and eye microscope and a lot of stuff. We have usually a small laboratory in the healthcare center, and we have digital records that are usually the same in the area and sometimes the same as the hospital have too. So, the chronic patients. This is one of my patients, Stina. She said that I could use this picture. She has a lot of different diseases, so she's a difficult patient. First, before I go into the health centers, I should say that there are some national initiatives on improving health care. There are in Sweden guidelines on a lot of chronic diseases, how they should be treated. And this is followed up in something called open comparisons. They publish a lot of data about how well we reach the goals in the guidelines. It's more from secondary care and kind of little from primary care, but still, it's a lot. and it could be better. So because of that, the government recently decided to put a lot more money into improving care of chronic care. It's not yet clear how this is going to be done, but they say we have to improve teamwork, we have to focus on medical results, we have to have systematic quality improvement, and that's what this money is supposed to be used for. So right now, the common teamwork is on these diseases. The GP and the nurse, they work together usually on diabetes, asthma, COPD, hypertension, heart failure, dementia, lifestyle interventions, depressions, and old patients with multimorbidity. I think these are the most common diseases. Actually, it's seldom one nurse. Usually it's a lot of nurses, and they are subspecialized. So there's usually one nurse who is a diabetes nurse, one nurse who is asthma nurse, and one is a specialist in hypertension. And usually the nurses took some, they've been studying this, they had some, different types of education, but you don't just commit yourself as a diabetes nurse. You have to have some good education, which is usually not paid by the pharmaceutical industry, but it's studies in university or something like that. And the responsibilities, usually the GP is responsible for the diagnosis in the first, and to decide about the treatment, the first decisions on the treatment. And then the yearly checkups, the doctor usually sees the patient and see what's new, what's happened, how are you, should we redefine the goals of the treatment, should we change the treatment, are there any complications? But the GP is also focused on the patient's agenda, and sometimes even if the patient come for their checkup on diabetes, they say, yeah, my diabetes, but right now I have a problem with my knee and my shoulder and this and that, and the doctor, focus on what is the patient's problem. And also many patients have many diseases. Comorbidity is common, as you know. And since we see our patients only once or twice a year, we take it all at the same time, and that gives less time for the systematic checkup. The nurse, on the other hand, is usually responsible for the starting up the initial treatment, following in the beginning to maybe, if it's like insulin, to increase slowly and help the patient with the checks of the blood glucose. Usually the nurse sees the patient also for a yearly control. Sometimes it's every second year the doctor, every second year the nurse, depending on how well the patient is. The nurse is responsible for routine examinations and lab tests, and usually a lot more of the lifestyle interventions are the nurse's response than the doctor's response. And also the nurse focus on, this is a diabetes checkup, this is the issue of the day. So the nurse do all these things that the GP tend to leave out because other things may be important that day. So a little bit, the doctor focus on the individual patient's issue, and the nurse follow the protocol a little bit more. That's not the whole truth, but a little bit. So just to exemplify, with diabetes, the nurse can be responsible for the feet examination. Do the patient need to come to a foot specialist, and she could refer the patient there? Is the patient referred to eye control? If not, the nurse might do it, or depending on the system, tell the doctor to do it. And follow up with insulin technique and help to find the right dose. Asthma, yearly checkups, do the spirometry and advice on smoking. Dementia, usually it could be like a home visit that the nurse does, will see the patient and the family and protocol, find out, helping with the diagnostics. And then there are other parts of the team too, but mostly it's just the nurse and the doctor. Food specialists, physiotherapists are involved, psychologists, but they're not as close as the nurse and the doctor. So this is an example from Kvarnholmen's healthcare center. They created a team for hypertension. And they said, okay, blood pressure, well, it was heart failure too. It requires many contacts until the targets are achieved. And a lot of the doctor's time is used, and it doesn't work that way. Why can't we use the nurse's competence? And before they started this project, they said the GPs had a constant lack of time. A nurse helped to check out blood pressure and to take blood samples, but the GP was the one in charge of calling the patients and tell the patients to come. Your blood pressure is not good enough, you have to come back to see the nurse and check it again. And then when the doctor called, the patient had other problems and it was lost, the whole thing. It took a long time and it was slow to reach the goals. And now they have clear roles. The GP set the goals for the treatment and prescribe the medications. And the nurse maintains the contact and see the patient and book, tell the patients to come back or follow up by telephone for the patient to come back and take new blood tests if needed and control blood pressure. And then, of course, they discuss with the doctor when needed to see that it's going the right way. And they are also, as I said, responsible for lifestyle changes. So this is, yeah. Well, shortly, the patients come to the GP and there is a high blood pressure. And then the GP send the patient to a nurse who see the patients for a few checkups or initiate an ambulant blood pressure. So the diagnosis could be set from this investigation that the nurse follows up. Is it hypertension or not? And if it is, the GP sees the patient for a treatment plan, decides about some medication if that is needed, or if not, the patient sees the nurse for lifestyle intervention. If medication is needed, they see the nurse repeatedly and do these tests and whatever is needed until they reach an acceptable blood pressure. And then there is yearly checkup. And as I said, if it's uncomplicated patients with not other diseases, the patient might see the nurse every second year and not see the doctor so much. I wrote, they call these results, but I think that is not a right way to, because it's not the same patients. This is average blood pressure, the last blood pressure from all patients with hypertension they had in this health center. But since the population might be completely different, I don't know if you can draw so many conclusions from it. Maybe they included more and more patients with not so high blood pressure since they simplify the process. We don't know that, but still it looks good. And this is a similar thing, but it's about diabetes. It's from Lindsdal's Healthcare Center. And this is more structure. They didn't write it down exactly the same way, but they have checklists and they defined what is whose responsibility very clearly. And that was part of a quality improvement project when they followed up all results from diabetes patients, and they were thinking, how can we improve? What do we need to do? And they ended up with this program where it was very clear who is responsible for what. So the GP's responsibility, this is example, newly diagnosed patients, how are their responsibilities? And then there are lists for when the patients come for a checkup or patients with complications and this and that. But this is not newly diagnosed patients. The doctor is responsible for the diagnosis, for these blood samples, for checking ECG, blood pressure, basic information, start the treatment plan, discuss the targets, discuss with the patient what is the patient's responsibilities, and plan the follow-up to see the nurse. And then the nurse is supposed to see the patient quite soon to follow up on all these things. Continue with the patient education, maybe also the family, talk about these issues, what is diabetes, and again about lifestyle, and discuss the targets, and so on. So it's very clear which person is supposed to do. So these are two examples of teamwork on chronic diseases. And one reflection is that, is this really teamwork, or is it just shared responsibilities? Partly I think it's just shared responsibilities. They do different things, and that's excellent, but maybe they don't work together as a team so much. And for patients who have many diseases, they might see an asthma nurse, a diabetes nurse, a hypertension nurse, and that's not so good. So then they need to find out a way to have several qualifications in one person. It doesn't work so well with patients with many diseases. Yeah, this is just about about comorbidity. We know that a lot, even among younger patients. Well, I don't know what is young. I guess it depends on your own age. So if I consider this as young, then around 50 years old. Well, so quite a few still have several diseases. A lot have more than one disease too. And then the time with the patient. The doctors spend, even if we spend a lot of time with our patients compared to many other countries, it's nothing compared to what the nurses do. Usually they spend an hour, at least half an hour, often an hour with the patient. So they have time to talk about all these things, and that is good in a way, but sometimes it turns into, with few, I told you over 16% GPs, and there are lack of GPs. So with too few GPs, we just try to think, what can the nurse do? How can we share responsibility? Instead of thinking, how can we use each other's competencies in the best way? On the other hand, there are really good things. One thing that happened, it might sound bad, but routine stuff is not forgotten. The nurses do what they're supposed to do. They don't forget about checking the feet on the patient with diabetes, but the doctors tend to do it, tend to forget. So that works better. And there is also, well, I would say too that the results, the medical results are achieved faster when we work together like that, because the nurse do these things. And there is some kind of extended continuity, which is good too. The GPs, they are not there for one reason or another, but the patients see the same nurse. Or if the nurse is not there, they see the same GP. So there are more persons involved, and that builds up continuity. Yeah, goals are clearer, and that might be, because since we have to communicate the goals between the nurse and the GP, of course they are clearer, and they are clearer to the patient, and maybe that's also, of course, a reason why we could reach them easier and faster. I saw you laughed when I had a male nurse. That's a nurse that he come with me to some home visits. So, thank you very much.